Cool. All right, so we'll go ahead and start with integumentary. And the cool thing about the integumentary system is we've already had a lab on it, so you guys should be pretty well primed. But there are just little details, a little nuance that I want to talk about. Okay, so just to recap, so the integumentary system contains the largest organ in the body, right? The skin. Three, sometimes up to 5 kilograms, okay, which is pretty significant amount of mass there, weight. And what is the role in the integumentary system? Well, it protects us, right? It helps us sense, helps us regulate temperature, okay? It helps us excrete certain wastes, and it also helps us synthesize vitamin D. And vitamin D is very important. We need that in order to do what? In order to
protect our skin, take in vitamins.
Vitamin D specifically. What is that? What do we need that for? What is it important for? We're absorbing something into our body. Calcium. There we go. Yeah, calcium. Absorbing calcium. Yeah. And in fact, people that don't get enough sun, okay, because it's actually, and we'll talk about this in a little detail here at the end of the lecture, but people that don't get sun, all right, cannot actually get vitamin D synthesized. They cannot synthesize vitamin D. They cannot absorb calcium in their diet. And they can develop a disease where their bones can become very, I don't want to say fragile, brittle, but their bones can kind of become stretchier than normal, and you'll actually see like their legs will bow out and their bones will bow out, and that is a disease known as rickets. Yeah.
How much is not enough sun?
Actually, you don't need much. You don't need much. In most places in the world, it's not a problem, right? You go outside for a few minutes a day and you're fine. But there are certain areas of the world, for example, certain areas of Russia, Siberia, and even up very, very high up in the Arctic areas, where you have very, very long winters, and you have months where you don't really have sunrise, months of very, very dark conditions. And in some of those areas, those people, because they're not getting any sunlight, specifically it's ultraviolet light that they need, they're not getting any sunlight, guess what? They are going to be very prone to developing rickets. And in some places, in the schools, they'll actually, several times a week, they will have the kids go into a room and they'll put on UV protective glasses. They're like, all right, take your clothes off. And they'll have a big ultraviolet lamp, and they'll turn that lamp on, and the kids will stand there, and they'll hit them for a few minutes with that ultraviolet lamp, in order for them to get the amount of ultraviolet light that they need.
So it's not genetic?
No, it's not. I'm sure there are some genetic disorders involving calcium, but rickets is not typically. It's actually a lack of sunlight. You don't need much, but yeah. And this is actually why one of the evolutionary, when we look at the evolution of this is actually one of the reasons why people that have lineage that comes from more northern environments, it's why they have fairer skin, right? There is a chemical or a substance in the skin called melanin. It's dark. And melanin is very good at absorbing ultraviolet light. Well, if for thousands of years, my family has come from very northern environments where there's not as much light, do I need a whole lot of melanin absorbing all the scant amount of ultraviolet light that I do get exposed to? No, right? So we see that fair-skinned people, okay, that have fair-skinned people, their lineage comes from these people that ultimately come from more northern climates. Yeah.
Is that why, like, when you stay on the sun too long, you get darker?
Yes, you have more. Not. Yes. yeah, what happens is your skin realizes, oh, I'm getting too much. That's really what it is. Your skin's like, oh, I'm getting too much ultraviolet light that can damage. I'm going to need to express more melanin.
So it's really you are making more melanin.
Yeah, yeah.
That's what tanning is.
Yeah, that's what it is, yeah, yeah. And that's why people that their lineage comes from environments where there's a lot more sun, they tend to be what?
Darker.
They tend to be darker. They tend to have more melanin because they have evolved to have more melanin to prevent that ultraviolet light from causing damage. Does that kind of make sense? Yeah, how about that, huh? So there are good evolutionary reasons for a lot of these things that we see. Okay, what does the integumentary system contain? Well, it contains the skin, it contains your hair, it contains various glands such as sweat glands, sebaceous glands, or oil glands, and of course it contains two major accessory structures, specifically the hair and your nails. Okay, so you have a whole lot of different things going on. The integumentary system is divided into 3 general layers. Okay, we'll just review. What is the outermost layer?
Epidermis.
The epidermis. All right. All right. And then what is this middle layer here? The dermis. All right. And then the lowest or the deepest layer is the hypodermis or subcutaneous. Good. Hypodermis or subcutaneous. Okay. So let's talk about the epidermis real quick. I know we talked about this in lab, but let's just go ahead and talk about it. So the epidermis primarily contains keratinocytes, right? These are keratin-containing cells. Okay. Keratin, as you guys recall from lab, is kind of a tough protein. It's more or less waterproof. It's tough. It has some strength in it. You guys know, or maybe you know, or you will know today, what happens when you spend a lot of time in the bathtub? What do you notice happens to your skin? It gets wrinkly, huh? What causes your skin to get wrinkly? Yeah, that's what a lot of people think, that it becomes waterlogged. Your skin is pretty much waterproof due to the different oils that are secreted on it and due to all that keratin. Actually, what happens is it's actually a reflex. Yeah, it's actually a reflex, and your skin wrinkles. And we think that it does that to make you grip things easier when you're in water. Yeah, so it has nothing to do with your skin becoming waterlogged. It is actually a reflex, and it looks like it actually improves gripping in a water environment. How about that, huh? Yeah, so your skin's a pretty good barrier. It's pretty good. It's pretty much waterproof, and you want waterproof skin, right? Because if it wasn't, all that water, because most of your body is water, all that water contained in your body would easily leak out. And what happens when you damage your skin? You lose water, right? You either bleed, and what's most of your blood? It's water, right? Or if you burn your skin, anyone's seen somebody with a significant burn, they seep water. The skin is no longer a good barrier to containing water, right? So it makes sense that your skin is going to be fairly waterproof. So the keratinocytes are constantly being created. Okay, they're being created at the basal layer, right? The corneum basal, as we talked about in lab. And then they are pushed outwards, and the further away they go from the basement layer, okay, the less nutrients they have available, because remember, the epidermis, what type of tissue is this primarily? This is stratified squamous epithelial tissue, and epithelial tissue is vascular or avascular? It's avascular, right? The vascular supply is actually in the dermis, and so how do these cells get perfusion? Well, they have to get their nutrients via diffusion, And the further away you get from that, the less nutrients those cells have, and the more likely they are to be dead cells, and ultimately the outermost layer of the epidermis, which is known as the, what's the outermost layer? And I just remember this. This is a common saying, and it's come, let's get sunburned. The corneum, there you go, right? The corneum. Right, the outer layer of the epidermis is the stratum corneum. Okay, it's rough, consists primarily of dead cells. Okay, this is sometimes known as the horny layer because it has a horn-like appearance on the microscope. All right, so that's the outermost layer, come. Okay, what's underneath that? The lucidium, right? Now, the stratum lucidium, is it found in all types of skin?
No.
No. Where only type of skin, where is it found?
Thick.
Thick skin. Remember we talked about thick versus thin, and there was that little typo in the lab manual? Right? So thick skin is where you have excessive amounts of mechanical stress, right? So palms, fingers, heels, those kinds of places. So in thick skin, you will have the lucidium layer, right? But in thin skin, you will not. You only have 4 layers, okay, instead of the 5, okay? In the lucidium layer, we call it lucid, or clear, because it kind of has a clear, translucent appearance. Underneath that, you have the stratum, or the the granulosum, which has kind of a grainy or granular appearance. Okay, and this is the area where you have a transition between dead and alive cells. The cells they're losing their nucleus. Okay, and so in this particular area is where you kind of get that anything above it's dead and anything below it tends to be alive. Okay, and then underneath that, okay, the sun, that's the stratum spinosum, right? And these contain little filaments and strands of connective tissue, or connective fibers rather. Okay, these are living cells. And then finally you have a single layer of, there you go, the stratum basale, the basal layer. It's a single column of cells, and these are your stem cells. Okay. These are the cells that are constantly dividing, that basal layer there, okay, making those keratinocytes. Now you have some other types of cells that kind of get mixed in there as well. Okay, you have melanocytes. And melanocytes, as you might imagine, do what?
Produce melanin.
Produce melanin, right? The melanocytes produce melanin. What happens is you do not really have more melanocytes. Every human being more or less has the same number of melanocytes. But what happens is the melanocytes have like a spidery-like appearance. And what happens is they actually grow and their little extensions extend out further. Okay, and that's what makes the skin color darker. As you get more tan, they extend their little filaments out further. Does that make sense? And then people that are less tan, or people that are more whitish or fair, their filaments are not as extended. Okay? And there is a type of skin cancer known as melanoma. You guys ever heard of that? Melanoma is a cancer of the melanocytes. Okay, it is when melanocytes lose their special function and then begin to divide uncontrollably. Okay, so that's one of the 2 major types of skin cancer, a melanoma. Okay, so they contain melanin. It's a dark pigment, right? It protects us from the ultraviolet light in the sun. Ultraviolet light is very high energy light, right? It's light that has a small wavelength. It's high energy, and that light is very good at breaking chemical bonds. Specifically, it's very good at breaking the chemical bonds that hold DNA together, so it can damage DNA, it can cause mutations. And those mutations can cause cells to die, or it can cause cells to become cancerous as well, increase our risk for cancer. And then it can also cause elastic fibers to kind of clump up. And have you ever seen somebody that spends a lot of time outside? You see it a lot down here, right? A lot of hardworking people spend a lot of time outside. And their skin kind of gets tough and leathery. And that's due to that clumping of all those fibers, all those collagen fibers. All right. You also have what are called dendritic or Langerhans cells. Okay, and these are very similar to macrophage. Okay, they do pretty much the same thing. They're phagocytic. Okay, they have immune functions. They come from your bone marrow. And as you might guess, if you, let's say you get a large let's say you sunburn yourself and you damage these dendritic cells, what have you done to your immune system? You weakened it. And so people that have burns, to include sunburns, will actually have a compromised immune system. So sunburns can compromise your immune system, make you more prone to developing infections and having problems. Yeah. We do see immunosuppression in people that have burns, including sunburns. And we'll talk about burns in a little more detail here in a minute. Okay, you also have what are called Merkel cells. Okay. And these are involved in sensory receptors, and there are special receptors. There are receptors that are in the dermis, the deeper tissue, that are good at detecting more stronger or more deep kinds of pressure. And then you have receptors that are not in the epidermis, but higher up in the dermis, that are very good at detecting light touch. And we've talked about that in the lab, so I won't really spend any more time on that as well. But it's a combination of the receptor and the nervous system that is responsible for a lot of the sensory functions of the integumentary system. Okay, you guys good so far? And then finally, when we talk about the epidermis, there is another type of skin cancer, common type of skin cancer, that involves the basal layer here, okay? And this is known as, if you had to guess,
Basal cell
there you go, basal cell carcinoma, okay? And it is a cancer of the stratum basal, or the basal. Right? Does that make sense? And that makes sense why we would call a certain kind of cancer a melanoma, or why we call it a basal cell carcinoma, because it's the specific cell involved. Does that make sense? And there's actually a little section. Yeah, there you go. You're right. I opened right up to it there. That talks a little bit about skin cancer in a little more detail. And there are some warning signs there. What are those warning signs? They're bullet points there.
Asymmetry.
So asymmetry. So when you see some feature on your skin, you know, like a little round, dark area, and you're like, well, is that a mole, or is it something I need to worry about? These are things that we look at as healthcare providers to determine whether that needs further investigation. So is it asymmetrical? Okay, so generally, like just a run-of-the-mill mole tends to be symmetrical, right? Like a symmetrical circle, right? You could cut it in half and it's symmetrical along the axis. But if something gets very asymmetrical in appearance, that's more problematic. Okay, so that's the A. What's next?
Border.
Border. Okay, what does that mean?
The border of melanoma is generally irregular and in some cases notched.
Yeah, so again, right, so you have a nice smooth border that's symmetrical. That is not as concerning as a border that is more irregular. Okay, what's next?
Color.
Color, okay, tends to be darker. And then what's next?
Diameter.
Diameter. And the general rule of thumb is anything that has a and you guys know what diameter is? What is diameter? What's the difference between radius and diameter? Because sometimes I will use those terms. So I say something has a...
Across.
Huh?
Across.
The whole.
The whole thing, right? So a diameter goes through the whole thing, and a radius is,
From the half, from the
yeah, it's just half your diameter. Yeah, from the center out. All right. So the diameter greater than a pencil eraser, than your standard pencil eraser, is problematic. So that's a nice little assessment scheme that we can use to go, hey, this little thing that we see on the skin warrants further investigation. The good news is if you catch skin cancer early, before it has metastasized, the cure rates are very high. You can go in, we can remove that area, and people tend to do okay. Now, people that develop cancerous skin lesions are at higher risk for developing other lesions, but if you can remove those lesions soon enough, the cure rates, the survival, and when we say survival, the standard way we talk about surviving cancer is what's known as a 5-year survival rate. So we look at how many people have survived after 5 years, and it's something like 95% for skin cancer. So it's very, very high survival rates if you can catch it soon enough. So there you go. Okay. So let's now talk about the dermis. The dermis has 2 major layers. Okay. So it has this layer here. Okay. We have this little wavy appearance. These are called the papillae, right? The papillae. And what is this layer here known as? The dermal, not the reticular layer, but it's the layer that involves the papilla. There you go, the papillary layer. How about that, huh? Right? The papillary layer, what kinds of tissue does a papillary layer primarily contain? Contains a very specific kind of tissue. Loose connective tissue, yes. Loose connective tissue, okay? And then right under the papillary layer, okay, makes up the bulk of the dermis is known as the reticular layer. Good. And the reticular layer primarily contains what type of connective tissue? Dense, irregular connective tissue. Okay, so loose connective tissue, the papillary layer, and then dense, irregular connective tissue in the reticular layer. Okay, you guys okay with that? I talked about the nerve fibers and the sensory receptors. The more shallow ones tend to be light touch. The deeper ones tend to be strong pressures and touches. Okay, we also have, what's this? What's this structure here? Sweat gland. Now, this is all new material because we did not talk about the different types of sweat glands in lab. So let's talk about them now. So you have 2 different types of sweat glands. Okay, you have what are called apocrine, okay, or apocrine, okay, sweat glands, and your apocrine sweat glands. I'll write that up there. Apocrine. Your apocrine sweat glands are kind of your run-of-the-mill sweat glands. Look at them as your run-of-the-mill sweat glands. Actually, no. Let's not look at them as that, because they're not. They're special, okay? But rather your eccrine sweat glands, your apocrine and your eccrine. Your eccrine sweat glands are your run-of-the-mill guys. What I have drawn here is actually an eccrine. An eccrine sweat gland, okay, has a duct, and it dumps the sweat right out onto the surface of the skin. Okay, right onto the surface of the epidermis. Okay, so an eccrine sweat gland, okay, secretes the sweat directly onto the surface. You guys cool with that? Now the apocrine sweat glands, okay, their sweat is deposited onto a hair follicle. Okay, a hair follicle. So eccrine, skin surface, okay, apocrine, the sweat is dumped onto a hair follicle. Okay. And this is important, really comes down to two areas of the body where the apocrine sweat glands are important, and that is in your groin and your armpits. Yeah, groin and armpits. And we do not see apocrine sweat glands begin to function until puberty. Yeah, until puberty. So prepubescent people do not have significant apocrine sweat gland activity. It is the eccrine activity primarily. And then as you become adult and you develop adult or sexual characteristics, we see the apocrine sweat glands become more relevant issue, and then you have to do what? Well, things like wear deodorant and shower becomes a bit more important as well, right? Body odor becomes a bigger deal in that case. You guys cool with that? Now, when we talk about body odor, is body odor caused by the sweat itself?
Isn't it toxins?
There you go. It's bacteria. It's bacteria actually. There's substances in the sweat that the bacteria eat, and then the bacteria excrete smelly molecules. Yeah, so it's actually due to the bacteria digesting the sweat in a sense. All right.
I have kind of a weird question, I guess.
Okay.
I read online, so you never know.
You never know.
You
Yeah.
never know, but I read that women who use antiperspirant deodorant have higher risks of getting breast cancer because they basically don't perspire out some of the things that they need to get rid of in their body. Does that sound pretty weird?
I don't know. I'd have to look at the studies. Are there good studies on it? I don't know.
I think it's because of the aluminum.
They do contain aluminum, and actually it's aluminum that's very good at coming in and blocking the pores. But I don't know how big of a connection there is with breast cancer. I know that one of the biggest connections with breast cancer, honestly, is genetic. There are genes, and there are people that have undergone genetic testing, and there are several people, and even famous people that they find this gene, and they've actually had mastectomies. Angelina Jolie, yeah, had some genes. So I don't know. I'd have to look at the studies. I don't know if that's a real. It may be like there may be some little correlation there, and you know about correlation and causation, right? I'm sure there probably is some correlation, and somebody looked at a study. The problem with correlating things, what's really tough there is you can correlate lots of unrelated things. For example, I could say that that global warming is caused by pirate attacks. And then I could say, but what have we seen as global temperatures have increased? We've seen lots of pirate attacks, right? A lot more ships are being taken over. So clearly pirate attacks must be causing global warming because they're correlated, right? Well, wait a minute. Let's look at it. There may be some other things involved. So I suspect that it may be some situation like that where there's a correlation, but not necessarily a causation. I don't know. I'd have to look at the study.
That makes sense. Like if she is more prone genetically to.
Yeah. So how many? That's and you have to be real careful when you do studies. And you have to be real careful. Like, okay, have you accounted for these other what we call confounding factors? And I don't know. I don't want to say one or the other, but I do know genetics play a huge role when it comes to breast cancer for sure. Cool. All right. So now what I want to do is I want to talk about vitamin D synthesis real quick, and just a few other odds and ends. And we should actually have you guys out of here reasonably early. All right. So definitely make sure that you can memorize the layers of the epidermis and the dermis, and thick versus thin skin. The differences there. So let's talk about vitamin D real quick. So So vitamin D is also known as, and I'll just write this up here real quick. All right. 7-dehydrocholesterol. That's a precursor to vitamin D. That's a precursor molecule. And so this molecule here gets hit by ultraviolet light, okay, from the sun, okay, and it becomes a bit more reactive, if you will, and then that reactive molecule travels to the liver, and I believe some of this happens in the kidney as well, okay, the kidney and the liver, where it is then turned into 1,25, and I'll just write this up here. AKA vitamin D. There we go. All right. And it is the vitamin D, okay, that allows us to absorb that calcium, specifically in the gut. Allows us to get that calcium, those calcium ions absorbed into the gut, and then that calcium can be deposited in the bones, and we don't get rickets. Okay. We did not talk about the hypodermis, the subcutaneous tissue, and I'll just mention that briefly. The hypodermis is subcutaneous. Is this vascular?
Yes.
And what major type of cell do we see here? Say that again. The adipocytes. Yep. The adipocytes. Yep. Adipose tissue being fat, or your fat cells, your adipocytes, right? Because they contain a lot of the fatty acids, so they get stored. Okay. Now, does this fat have an important role? So we always think of fat as a bad thing, but does it play an important role? Yeah, it protects deeper tissues, right? It's cushioning, but what other role does it play? Stores energy, right? And most of you guys have gone without eating, right, for a while, and most of you, some people don't tolerate this very well, though. Some people do not tolerate fasting very well and then get hypoglycemic or low blood sugar. But people that fast, okay, and this has become an area of intense discussion in terms of lifestyle and dieting and that, and it's something known as a ketogenic diet and that. But when we fast and we run out of glucose in our blood, what can we do to make ATP? Yeah, so what we do is we start breaking down fat. And we turn fats can be turned into a molecule known as acetyl-CoEnzyme A. And acetyl-CoA can then be fed directly into the Krebs cycle, so we can make ATP. So fats are very good, very efficient way of storing energy, but when we break fats down to make energy, there are lots of waste products that are created, what are called ketone bodies. And these become significant in certain disorders, and we'll talk about those a little later on, because I believe that I'll be talking about the endocrine system with you guys, and there's some really important endocrine problems. Okay, let's see. Let's talk about burns real quick. So when we have burns, and it talks about this in the book as well, there are two general types of burns. There are what we call superficial or partial thickness burns, and then there are what we call full thickness burns. Okay? So what do you think partial thickness burns involve? So partial thickness burn is going to involve what? Just the epidermis, right? Partial thickness burns are going to involve just the epidermis. And full thickness burns are going to involve what?
The epidermis, dermis.
And the dermis, yeah. At least the epidermis and the dermis, okay, may even involve the subcutaneous tissue, okay? So what you need to know about burns is what structures are going to be involved. If I have a full thickness burn, okay, somebody gets burned and their hairs are just like falling out, or you can just kind of, you're touching their hairs and they just kind of fall out or get pulled out very easily. What is that an indication of?
A full thick.
Full thickness burn, right? Because where are the hair follicles? Yeah, they're in the dermis, right? You guys cool with that?
Yeah.
All right. All right. So there we go. Now, things you need to be concerned about burns. With a full thickness burn, what have we damaged? Okay, we damaged everything, but when it comes to repairing, what is going to be kind of important here? The what? What layer is this? The stratum basal, right? We have destroyed those stem cells. So if I burn, okay, through the epidermis and I take that layer out, will there be epidermal regeneration that can occur?
No.
No, right? And so what do we need to do in that case? Skin grafting, right? Yeah. So people that have significant damage to this from burns, they cannot regenerate normal skin, and you will need to do a skin graft. You will need to take samples of healthy skin from non-burned areas of the body, and then you will grow them, culture them, okay, over an extended amount of time, and it'll get larger, and then you take that and put that over the burned area. Does that make sense? And does it make sense why we would need to do that? Because we take out those stem cells in the basal layer. You guys okay with that?
Do they just place it on there, or what do they do?
No, they graft it in.
Oh.
Yeah, they have to graft it in, and they have to sew it in, and then, make sure that it establishes. Yeah, so it's a bit more nuanced than that, but in essence, they kind of just slap it on there. Yeah. So you guys cool with that? Okay, let's talk a little bit about skin color. So the skin color may tell us about how our patient's doing. Okay, and I had mentioned one type of color earlier already, and that is a yellowish color or jaundice. And what does that indicate? Indicates an increased level of bilirubin. And in an adult patient, that indicates a disorder of what? The liver. Okay. And I know you guys will probably talk about this in the gastrointestinal section, which I believe is next semester. I don't think I have that in my section of anatomy and physiology. But what happens is when your red blood cells die, one of the wastes that's produced is something called bilirubin. Generally what happens is that bilirubin goes to your liver, and your liver attaches a molecule to that bilirubin, or what we call conjugates it, and then that bilirubin is excreted in your bile. Okay, so it goes in your bile, it goes in your gallbladder, and then your gallbladder excretes that out into the intestines, right? And it is actually that bilirubin that gives bile kind of that yellowish, kind of its yellowish color. So if you have a liver problem, you have cirrhosis or some sort of liver damage or disease, your liver may not be able to conjugate that bilirubin, and then that bilirubin levels will increase, and you will see that yellowish coloration of the skin. Does that kind of make sense there? Okay. And there's some other things that can cause bilirubin to increase in newborn patients. Sometimes newborn babies will have what's called hemolysis, where lots of red blood cells break down in a short amount of time, and the amount of bilirubin that's released is just overwhelming for those babies. And you can get what we call hyperbilirubinemia, high bilirubin in the blood of the babies. And what's really good at breaking bilirubin down? Sunlight. Yeah, ultraviolet light. And so sometimes you'll have to take those newborn babies and place them. You put little goggles on them, and you'll place them in ultraviolet light, what we call a bilirubin.
You told me just to put them in the window.
Put them in the sun, yeah. And that's actually, it was actually a nurse, I believe, a couple centuries ago, it was a nurse that noticed this. that babies that were in the sun tend not to get as jaundiced. And so that was standard treatment for jaundice, and now they have Billy lights. For like minor, if it's relatively minor, they may just say, oh, take him home, put him or her out in the light. If it's really, really, really high, they may throw them under the Billy light for a little while. There you go. Okay, some other things. There are some tumors specifically. There is a tumor of a gland within your brain, pituitary gland. Yeah, a specific type of pituitary tumor. And what this pituitary tumor can do is it can cause the secretion of a hormone. Okay, those cancers, those tumor cells will secrete a hormone that stimulates the melanocytes. And so you will get this really hyperpigmented bronze statue coloration of the skin. And that may indicate that you have this pituitary tumor. There is another disorder called Addison's disease. You can get the same kind of bronze color. And Addison's disease, you can even get dark discoloration of your gums as well. Okay. Vitiligo, of course, is, you guys familiar with that? Vitiligo. It was a disease that Michael Jackson actually suffered from, where you have what? Yeah, you have a loss of melanocytes. You actually lose the melanocytes, and so you become what? Become very fair-skinned. And of course, this is very notable in people that are very dark-skinned that develop vitiligo, and their melanocytes go away. And what happens? They get very light. It could be, it's not a deadly disease in the conventional sense, but certainly from a social aspect, it can be very problematic, as far as your body identity and how you look at yourself, how you think other people look at you. And then the other one, which is very common, this is something known as cyanosis. And what's cyan? Blue. Yeah, cyan's a bluish color. So cyanosis is a bluish discoloration. What does that generally indicate? Generally indicates that there is low levels of oxygen. Okay, it may be that you're having a breathing problem. You're not getting oxygen into your blood, or if you crush an arm or a leg, or you put some pressure on there and you block circulation, you can actually get cyanosis that way as well. But either way, it indicates that there's a lack of oxygen in the blood flowing to that cyanotic area, and that can be very, very problematic. All right, you guys good, so cool so far? All right, just a couple more things to talk about, and then, I'll have you guys out here a little early, so you get a little extra time to study. How about that? All right, so moving right along. I want to just quickly talk about the accessory structures. The two accessory structures include your hair and your nails. Okay, so here I have the hair follicle. Right, the hair follicle, its bulb receives blood from the hypodermis, comes up. Okay, there is a muscle attached to the hair follicle known as a what? Erector pili, right? Or erector pili. And that causes the goosebumps. That causes, right, the hair to stand up. Good. Now there is a gland associated with your hair follicle as well. What is that gland? It's a sebaceous gland, right? And sebaceous glands are not like apocrine, right? Apocrine sweat glands secrete a watery sweat onto the hair follicle, but rather the sebaceous glands secrete sebum, which is primarily composed of oils, fatty acids, oily. And so as that hair, is pushed out, those cells are covered in the sebum and they're oily, and that makes your hair more or less, kind of gives it some waterproofing, right? Kind of gives it kind of an oily, waterproof kind of character to it there. You guys okay with that? All right. So that's your hair follicle. Okay, remember it's deeper in the dermis. All right. And then I want to talk real quickly about nails. Okay, you have nails on the distal ends of your fingers. Okay, And evolutionarily speaking, nails are for protection. And do we see nails in most other mammals, or what do we tend to see in other mammals? Claws, yeah. Yeah, it was a defensive and offensive mechanism for hunting or for protection. And then as we become more human, we become more reliant on tools and things like that. And we don't really use our nails as a form of defense like other animals do. So when we look at the nail has a root, and you have a much better picture than I could ever draw in the book there, but you see you've got a root there. Okay, and a nail is created in much the same way as hair is. Okay, at the root you have cells dividing, okay, and then they push out, okay, and then as that nail is formed, you have dead cells. And then the nail sits on top of a dermis-like layer, okay, and so you do not have epidermal tissue right underneath the nail, do you? And if you ever damaged your nail, you would know that you have lots of bleeding and lots of pain. It's very painful, right? It's very painful. Lots of nerve endings there. It can get real bloody. And we know that with just simple damage to your epidermis, you tend not to have a lot of pain, and you tend not to have bleeding, right? Because you don't compromise the vascular or the blood supply there. Okay, and then finally, let's talk a little bit about healing and about wounds and wounds healing, kind of how that works out. Okay, so we talk about healing. The first thing that needs to occur is we need to stop the bleeding, right? The blood loss needs to stop. Okay, and we won't talk about all the details because it can get very detailed and there are different pathways, intrinsic, extrinsic. But ultimately, what is formed to stop the bleeding? A clot, right? A clot is formed. Okay, the bleeding is controlled. Okay, the inflammatory process occurs. Okay, immune cells and nutrients rush into that injured area. Okay. And then you have those stem cells begin dividing, okay? They begin filling the injured areas back in, okay, with what's called granulation tissue. Okay, granulation tissue starts filling the area in, and eventually you get healing. However, when you have these injuries, do you ever get perfect healing? Does it ever go back exactly the way it was before? No, and you have tissue that's a little different, and that's known as a what? A scar. Now, some people can go on to develop very large scar-like structures known as keloids. There we go, known as keloids. Okay, and this is a big problem with major burns. When they develop keloids, particularly if you get burns, in areas where you have articulations. If you get keloids, these big thick scars that develop over articulations, you can actually have limited movement of your joints. That becomes a really big problem. And people that have burns to their limbs tend to have reconstructive surgery where they have to go in and they have to cut through the keloids and kind of reestablish some mobility back to their joints. And some people are more prone to keloid development than other people, where they tend to develop these large keloids. And again, they become more problematic when you're talking about articulations where you have areas of movement. All right. Now, another thing that we need to worry about when it comes to wounds and wound care, and this is particularly important for any of you guys that are going to be going on to maybe not necessarily veterinary medicine, but if you're going to be in some situation where you're going to be repairing somebody's wound, okay, or what we call suturing. You guys all heard that term, suturing, or sewing a wound up, or closing a wound. This is a really important concept. In addition to making sure it's clean and all that because of infection, okay. you have these collagen fibers tend to be aligned in very specific configurations in the body. And there's actually a little diagram in your book as well. But these are called cleavage lines. Okay? And these are just natural lines where collagen fibers kind of go. And what happens is, if you have collagen fibers, let's say that the cleavage lines are normally kind of oriented in this direction here, okay? And I have an injury, okay, maybe I have a laceration here. Do you think that's going to be relatively easy to repair because it is in the same direction or aligned in the same way as those cleavage lines?
Yeah.
Yes, right? It's going to be easier to sew that up, to close it up, and it will want to seal up the scarring with minimal. But the other situation is, okay, so I've got these cleavage lines here, and now I have an injury like this that runs perpendicular. Is that a problem? Yes, that's going to be much more prone to scarring. And so when it comes to closing a wound, we need to be very careful. You're not going to have to know where the cleavage lines are for certain areas of the body for this class. But in general, we need to be very careful about looking at that patient. Where are those cleavage lines going? And how can I best align that wound, realign that wound to minimize scarring? And where do you think that is most important? What area of the body does it become most important? The face, yeah, the face. And in fact, in some hospitals, aligning those wounds and closing those wounds appropriately is such an important thing that anybody who has a facial injury cannot have that injury closed by a regular doctor. That they actually call a plastic surgeon in to come in and deal with those facial injuries, even relatively minor ones, just because it's such an important thing, and because it can be very life-altering for people if they develop large scars and keloids and things like that. So that's yet another thing that you need to be careful about when it comes to wounds. All right, guess what? We have made it through all of the material that we need to. We're right on track, and we're just a little early too. So do you guys have any questions? Or do you feel relatively comfortable with the material? Cool. All right, so I will see you guys in lab. I'll have all your lab reports back for you on Thursday, and we will be starting lab 7. Which, no, lab 7, yeah, we'll start at regular time, but yeah, introduction to the skeleton, and I think you guys will find it won't be a terrible lab. We'll ease you guys into it, but the next 3 labs, or the next two labs following that one, you're going to have to do a lot of memorization, and I know what I found is sometimes you kind of tend to skip over those models, you know, the cell model and that. Some people just kind of, whatever. It's going to be really important because you're going to have different bones just laid out on a table, and you'll have to identify parts of the bones, what kind of bone it is. So it's going to be really important to work through the different models that we have up for the next few labs, and make sure that you're comfortable identifying, okay, what type of bone is this? Where is it located? What's its function? Those kind of things. So, even though it seems like a simple lab, do take a little extra time to make sure you're really comfortable with the concepts. Okay, guys, have a great night.